Recruiters calling or texting you nonstop? Want to find the right job without exposing your personal info? Need tools to manage your search all for free? In every industry, there comes a moment when innovation challenges the status quo, ushering in a new era of possibilities. Beginly gets it. They get us. Their platform anonymously matches you with jobs that suit you until you decide to share your info. Customize your job search based on economic factors like salary or cost of living, or non-economic factors like location or nearby stadiums or airports. And their algorithm does the rest, all for free. Ready to find your perfect job? Visit beginlyhealth.com/doctoring. Powered by preference, connected by passion. You're on a flight. There's an overhead announcement asking for a doctor. What's the emergency? Can I help? Can I handle it? What if I can't? Take a deep breath and unfasten your safety belt to go assist with an in-flight emergency. Find out why and how and what it might be. Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. On today's episode, we're going to be covering a topic that I've been wanting to do for the longest time and finally found the perfect guest to interview about this. So we have Dr. Christian Martin-Gill. He serves as the chief of the Division of EMS, the EMS Fellowship Director, and is associate professor of emergency medicine at the University of Pittsburgh School of Medicine. He also serves as a medical command physician at the UPMC Medical Communication Center, StatMD, which provides ground-based medical support for national and international commercial airlines. Dr. Martin-Gill has extensive experience in managing in-flight emergencies and has published a study of almost 12,000 IMEs in the New England Journal of Medicine, as well as a review article for how to handle them in JAMA. So as you can imagine, what we're talking about today, in-flight emergencies. So Dr. Martin-Gill, thank you so much for being on the podcast.
Yeah, thanks a lot for having me.
So the first thing is more of like a statement. You'll correct me if I'm wrong here. It was going to be how frequent medical emergencies or in-flight emergencies are, but I was able to look that up. And from what I found was it's about, there are 45,000 domestic flights a day, and the odds of having one is about 1 in 600. And so that means about 75 emergencies a day. So if you're a physician getting on a flight, your odds of being called around 1 in 600, but just to give some scope, 75 of them happening a day.
Yeah, interesting. You're quoting our study there from the New England Journal. 1 in 600 was the rate that you see when you define an in-flight medical emergency in terms of what results in a call to a ground-based medical support service where we're assisting in in-flight emergencies. So that actually probably undercounts emergencies that might be much more minor, something that can be handled by the cabin crew and things that wouldn't necessarily generate ground-based medical support. But yeah, it's interesting. Worldwide volume of flights is about 4.5 billion passengers a year. And, some estimates would say that it's between several hundred to over 1,000 in-flight emergencies worldwide a day.
Okay. Just to put things into perspective. So unlikely to happen in one individual flight, but over your career flying, you're probably going to be in one or two. So let's start, because we're all, not all, I'm projecting here, me. When I get on a plane, I'm always worried, what if there is an in-flight emergency? What's it going to be? Am I equipped to handle it? So let's start with just what are the most common events?
Yeah, so looking at publications out there, we had an opportunity for a review article to look at 14 publications that are out there looking at the incidence of these emergencies across, various airlines. And the top 3 would be syncope or near syncope, respiratory illnesses or GI complaints. Interestingly, from our own experience, we see much more syncope and near syncope in U.S. airlines, domestic traffic here in the United States. And it's more common to see GI illnesses and febrile illnesses, so things that are more likely dealing with infectious causes in other non-U.S. travel, probably associated with longer travel, more meals eaten on board. Not necessarily that they're getting sick there, but that maybe getting more motion sickness and other issues.
I can imagine you're mentioning what gets called to ground control. And so if someone has syncope, I can imagine it's going to worry the crew and they're going to call, right? Like someone passes out. Oh my God, they passed out. As a physician, maybe we wouldn't be as as jostled by something like that, especially if we know it when we see it, we're like, oh, okay, all right, they'll lay them down, they'll wake up, they'll be okay. But for GI emergencies, like what would warrant something of such severity that they'd be calling the ground?
This really gets at the, policies of the airline and just the fact that the commercial airlines use ground-based medical support as a resource. So in fact, they're generally encouraged to contact a medical specialist that is trained in handling these emergencies, that handles, hundreds or thousands of these cases. And particularly when it may be beneficial to use the onboard medical kit and to provide guidance regarding a specific medication. It may be that kit has something for nausea for that GI patient that you're describing. And we might, want to make sure that we have a trained medical provider in emergencies and in-flight emergencies specifically, so that we can provide guidance about what's safe to use, what should be used, and other things. So it can be particularly helpful to get that input from somebody that and that is going to be able to provide that assistance.
Okay. So like just ultimately the magnitude of it, like the magnitude of the vomiting that's happening and the relentlessness of they're really worried about something happening to this person acutely. So it's going to be a pretty impressive event to warrant ground control. But apparently that's happening with some frequency.
It is. And I would say it isn't necessarily that it is such a severe emergency, but instead that if you think about the lay public or even flight crews, they're not healthcare professionals. So when somebody raises a medical complaint, it's hard to tell for a lay provider or a lay person that it is serious or it isn't. If somebody is having what we would maybe define as a mild or minor abdominal discomfort, they don't know it's not appendicitis. So they don't know, what exactly it is. And so they may get guidance. So a lot of what we do from the ground is just get a very basic history and make that quick determination of whether it sounds like something is likely to be serious or not, whether we need to provide any medical treatment or not, and go from there.
Okay, so syncope, either GI pain or some type of GI distress, right? What are some of the other more common ones?
Yeah, so respiratory emergencies are fairly common. Folks can get hypoxic at altitude or have respiratory conditions that don't do well at altitude. And so it could be fairly common for somebody to suddenly feel short of breath once they reach, an altitude cabin pressure. Other conditions might be really the gamut of things that might happen. Anything from somebody having chest pain to a suitcase falling on somebody's head. They may have tripped on the aisle. They could have infrequently an obstetrical emergency. Yeah. Really, if you think about it, the volume of passengers that are in the air right now would be many cities large. The frequency by which you might have anything happen at any given time can happen in the air.
Got it. It's not just that it's happening in the air. It's that it's just the volume of people. So anything that can happen will. And despite the number of times that they remind us that things in the overhead compartment will shift throughout the flight, people still have stuff fall on their heads.
That's okay. Exactly right.
So what about that kit, that medical kit? So what should we expect to find? And what's the standardization?
Yeah, so this in the United States is regulated by the FAA, and Federal Aviation Administration regulates for a specific set of basic medical equipment to be on every commercial aircraft beyond a certain size, essentially those flights that need at least one flight attendant. And those aircraft are going to have an automated external defibrillator, and they're going to have that flight crew member trained in how to do CPR and get recertified appropriately. And then the basic medical kit's going to have a variety of things that really treat the vast majority of emergencies that we see up there. They're going to have some basic equipment like a stethoscope and a blood pressure, basic setup to be able to start an IV.
Wait, a stethoscope. I can't imagine that being useful with all the noise. It's hard enough to hear anything to begin with.
Yeah, we do have to walk people through doing a palpated blood pressure. That is a fair point. Try to auscultate lung sounds on an aircraft is quite difficult, but it is there along with it.
Sorry to interrupt. Yeah.
Yeah. Ability to start an IV, to give a small 500cc bag of fluid, and a variety of medications that actually deal some of the common emergencies, cardiac conditions. You've got aspirin and nitroglycerin. In fact, for the very unfortunate and very rare instance of a cardiac arrest, you have epinephrine that can be administered intravenously, lidocaine, atropine. For common things like allergic reactions or respiratory emergencies, you've got intramuscular epinephrine, Benadryl, albuterol, and
Albuterol, like a nebulizer, or are we talking
inhaler.
oral albuterol?
As
There's
an inhaler.
there's like a meter dose inhaler with a spacer.
Interestingly, most do have a
Okay,
spacer, but that is one of those things you learn how to make very quickly, MacGyver style.
Or you could even call, I would imagine there's someone on an airplane. There's probably someone else that has their inhaler and their spacer, hopefully.
Exactly. Yep. Even toilet paper roll will get one in a pinch.
Speaking of which, is there anything else that we could use in a pinch? Because I would imagine, like, hey, is there anyone in the flight that has their EpiPen or that has a glucometer, or there, are there other things that we can MacGyver style that we can take advantage of that people probably have in their bags?
Yeah, and it turns out that different airlines actually have additional equipment than the basics on their kits. So they purposefully will have additional items, including a variety of additional medications, particularly for airlines that might be in longer haul flights, or certainly international destinations and things like that. But yeah, the items that aren't standard in the FAA kit that I think are most valuable are a glucometer, as you mentioned, a pulse oximeter, just a little cheap finger pulse oximeter that could be used, is not actually required, though many airlines do have one. And if you have certainly a medical condition, then you should carry your medications on board. And if you have a history of significant allergies or allergic reactions, then having an EpiPen, particularly for yourself, is of value.
Yeah. Although I'm sure there are a lot of people out there who, I left it, they'd take it with them some of the time or most of the time, but not all of the time. What do you bring? I'm wondering, when you go on either a short flight or a long haul flight, is there anything extra stuff that you bring with you?
Yeah, I've had the opportunity to assist in flight medical emergency in person. I've attended to thousands over the radio or phone. The biggest thing that I would carry is a pulse oximeter. I do have a low glucometer that I've carried at times. And other than that, to be honest with you, the vast majority of in-flight emergencies are adequately handled with the equipment that's on board.
Yeah.
And in fact, even without those two items, with the required contents from the FAA kit, we're adequately able to address the emergencies that happen in the vast majority of cases.
When a flight leaves from the United States or is traveling to the United States, is there any necessity for them to carry things that are mandated by the FAA, or that is only domestic airlines operating internationally or domestic flights?
Yeah, you're getting a little bit into the legalities of aircraft operations. What I can tell you is that U.S.-based airlines that are regulated by the FAA must have the contents of the FAA mandated kit.
Got it. So you're beholden to the country where you are, where you're stationed. Doesn't matter where you're going to or coming from so much as where you are based.
Correct. Or if you're doing domestic travel, also within that airline or within that country.
What role because you said you've been involved on the ground as that person that the in-flight crew will contact. So then if they're calling for a medical emergency, at what point do they holler over the intercom, is there a doctor on board?
Yeah, so that's really dependent on the situation and then the staff that are there. It may be that a flight attendant really needs assistance very quickly. They could potentially ask for somebody on the flight to see if they can render assistance immediately. But most often when ground-based medical support gets contacted, what happens is that somebody raises a concern. They tell the flight crew that there's a medical complaint or medical concern. That flight crew member will talk to the captain, who will radio the communication center either by radio or a satellite patch. That communication center will get a hold of two different centers. First, or not necessarily in order, but the ground-based medical support center that they work with, as well as their dispatcher. So it's their operations center on the ground. And suddenly, very quickly, we have a line connected with about 5 or 6 individuals all working together on that line. So it'll be the captain of the aircraft or potentially the first officer. It could then be the individuals from the ground-based medical support. At UPMC, we work with physicians that staff all of those calls. So we have a physician there immediately available. And then we have folks from communications and also the dispatch for the airline.
Okay, so they're probably calling because there's something really acute happening and they're like, we need someone right now. Like, we can't wait for the pilot to call someone who picks up and connects and right? Because there's a little delay there, although I would imagine that happens really quickly. They're just like, there's something happening right now as someone vasovagaling. Someone's vagaling, their eyes roll back in their head, they lose consciousness. Is there a doctor on board, right?
It may happen that way. It can also happen, it's very common for a ground-based medical support system to be called even before anybody's been asked to volunteer assistance. And in fact, it may be cases where we will request for them to make that overhead call so that we can get a trained healthcare provider, if one is available, to be the eyes and ears. And particularly if we think that there's going to be the need for the medical kit to be used, and particularly for certain interventions, then we're going to be looking for that provider on board who can render assistance.
So it sounds like when they're making that overhead announcement, they're looking for someone to be an extension of the physician that's been contacted on the ground. You're not alone up there. You're not the sole decision maker. You're not the one who's making the decision. The onus is not on you to land the plane or make the decision to land the plane. You have someone trained in this who's answering the call, and they're just asking you, hey, can you feel a pulse? What does the patient look like? So to be an information again, kind of like you're a medical student or an intern again, like you're there to gather information, less to make decisions.
Yeah, so I think the key is to work as a team. So when you have that healthcare provider on board, you're exactly right. That the great value of that individual is to get a history, to do an assessment, to be able to get a set of vital signs, and then to communicate those key details. It's important for folks that might be cautious about raising their hand in those types of situations to not feel like they're alone. And in fact, if the worry is that suddenly you'll need to make a big decision about diverting the aircraft or not, or that all eyes will be on you for what needs to happen, that doesn't necessarily need to be the case. And in fact, rarely, because you're working as part of a team that is running assistance. So yeah, being able to be the eyes, ears, and hands there on board with that patient at the bedside or that other passenger, that's really the true value.
Leading a medical practice is challenging. There can be reimbursement changes, referral slowdowns, staff turnover, or drama. There are obstacles in the way of achieving your goals, or maybe it feels like you've hit a plateau. Who can you turn to for help with the business of managing a medical practice? The Physician Growth Accelerator, a private practice partner that helps you uncover and overcome constraints in your practice. They will check your business vitals, identify the root cause of what's restricting your growth, prescribe what to do about it, and help you achieve it, just like we do with our patients. Imagine your practice, where stress is reduced, profits increase, and both patients and staff, and you are happier. They've been making that vision a reality for over a decade. Isn't it time your practice thrived? Discover how at physiciangrowthaccelerator.com. If the patient is able or there is a family member available, should I be having them sign some type of indemnification note that says that if things go awry, I won't be held liable? Listen, I'll help out, sir. I'll help you, but I'm going to need you to sign this first.
Yeah, certainly they're not going to do that if they just passed out and they're still trying to wake up. But no, I think what you're bringing up is, what Good Samaritan protections are there available? And the good news is that there's an Aviation Medical Assistance Act that protects that layperson from, or that healthcare provider when they volunteer to render assistance. And that Good Samaritan provision is fairly robust. In fact, it protects individuals in good faith rendering assistance on board for an emergency. And it also protects the airline itself from accepting the assistance of healthcare volunteers on board. So it's really, again, emphasizing that collaborative team to be able to help somebody on board and just recognize that it's location with limited capabilities. And we all just need to work together and not be worried that it's just going to lead to a lawsuit.
Yeah. As long as you're being reasonable, right? If you've got someone comes in abdominal pain and you're trying to use a butter knife to do a tracheostomy, right? Like, there are limits. But as long as you're in good faith here, you shouldn't, shouldn't be something on your mind. And in the little research that I did, I couldn't find anything that said that there had ever been a lawsuit. So there's no precedent for it. So given that there are so many emergencies every day, and still there haven't been any lawsuits when someone's been helped, that really should speak to how safe it is to be that helper.
Exactly. Yeah. Certainly there's a provision for gross negligence or willful misconduct. But the reality is that, as you mentioned, I'm also not aware of any completed lawsuit where somebody has been held liable for negatively and for rendering assistance as a, Good Samaritan volunteer. Interestingly, we're talking now about United States laws. And the other flip of the coin is that in the United States, along with several other countries, there is no requirement for a healthcare provider that's off duty to render assistance to help a passenger. That's not the case in other countries. So in Australia and many European countries, there's actually a duty to act for a healthcare provider, even if they're off duty, that they should render assistance in those cases. So whereas in the United States, there is a U.S. law, in other countries, there is the Montreal Convention internationally and other laws that dictate what needs to happen there. And in reality, the best thing is to try to help somebody out, to try to render assistance. And that's just the best course of action. Try to be that helper and just recognize that if you are somebody that may be outside of your specialty based on the complaint of the passenger, then you certainly can get a history. You certainly can help out, figure things out, and know that you're going to have somebody on the ground that's going to be able to provide assistance, help make decisions, or know what medications to use.
You still went to medical school, you still did residency training, and you still think like a physician. Like, if one thing is our training teaches us to think differently than before we were trained. So it's interesting, though, about the other countries, because I guess it's a product of socialized medicine. It's like, we trained you to be this professional, right? They're not out of pocket for their training. It's like, it's part of the, it's socialized medicine. And so whether we're in the air or on the ground, you are one of our doctors. And for us, it's a private system, so you don't have the duty to act, although there's some ethical obligation there, right?
Yeah, it's interesting. I think when you look at some of the publications that have looked at the various laws that would dictate this, there's certainly lack of consistency across countries, but what seems to come out is really the ethics of being somebody who's trained to help a fellow person and wanting to go ahead and render that assistance and just assist and do what you can. And I think that some of those laws and some of those requirements really just come back to that foundation of you're a trained healthcare provider, somebody's a medical assistant, go ahead and provide assistance and help out, and then we're going to protect you for being that person.
So speaking of responsibility, right? Whose responsibility is it to make the decision to divert the plane? Like, who does that fall? Does that fall on you as the ground crew healthcare provider? Is it the airline? Is it the pilot? Is it me as the emergency provider?
Yeah, there's a simple answer to that, and it's the captain of the aircraft. So that lead pilot for that aircraft is ultimately responsible for the passengers on board and has to make an ultimate decision about whether they continue on to a destination or whether they would divert. In practice, that decision is informed by anybody the captain or lead pilot has available, any information that they have. In fact, one of the great benefits of a ground-based medical support physician is to be able to assist in that decision from the medical perspective. And that pilot's going to be on the radio or phone with their own dispatcher, their own operations center, to make decisions about, is it safe to land? Has a flight just taken off overweight? And we may have to have operational considerations about when and where that aircraft would be able to land, what is an appropriate destination for that size aircraft, and a variety of other operational considerations. So there's a lot that goes into it. And exactly, that healthcare provider that's volunteering on board, that decision is not going to be burned on them. What you realize is that pilot's going to ultimately be responsible and be trained and capable of making that decision for the safety of all passengers, but also informed not only by that volunteer on board, but everybody that's involved in the incident.
So the ground crew that's helping make the medical decisions, they are contracted out, by the airline. They don't work for the airline. Because I would imagine if they work directly for the airline, there'd be some conflict of interest, right? Because diverting a flight is very expensive. So if it's something like, well, I don't know, this patient's probably going to be fine if we continue on to our destination. Well, it's an elderly person. They probably won't get much from litigation anyway. It's worth the chance to land the plane and save us a couple, whatever, 100,000s or millions. I don't even know what magnitude they work in here. But like, I could see that being a scenario. Tell me that's not what happens.
Well, I understand the question, and others have asked it. The reality is that there are physicians that provide ground-based medical support services that are either contracted through other entities like ourselves at UPMC or that work for an airline. What I can tell you is that physicians make decisions that have financial implications every day, every patient. We make decisions about whether it's appropriate to get an MRI, to get multiple CT scans, to admit a patient to the hospital, to admit somebody to an intensive care unit, whether somebody needs surgery. All of these have very serious financial implications. They have implications for the patient, first and foremost, the physician, the institution. These are our jobs as we make medical decisions that keep the patient at the center of that. And so it is first quite common for us to have to do it in every other environment that we practice. Second, I'd say that the airlines themselves have an interest in the safety of those passengers. It's much more important to make sure that one passenger is safe and is taken care of than it is to have a simple diversion of an aircraft. Diversions happen not infrequently. And if that's what needs to happen for the safety of that passenger, that is exactly what the airline's going to do. So it's really a common occurrence. It's something that airlines take seriously, but it's something that's going to happen if it's in the best interest of that passenger. Now, on the flip side, I would tell you that it's also in everybody's best interest to avoid diversions that are not beneficial or that are not likely to be helpful for anybody. And in fact, I've been on quite a number of calls where we might have suggested that a diversion may be the safest option, and yet the passenger themselves did not want to divert the airplane. Imagine that you get on a plane in Philadelphia and your plan is to go to Los Angeles and somebody's about to drop you off in Kansas.
Yeah.
Your chest pain may feel a little bit different if you realize you're not going to make it to your destination. So again, it's about being a team. It's about, just as we do on the ground, talking about risk and benefits, we think about those in the air. And at the end, it's trying to do the right thing.
I would imagine that happens to you sometimes in the emergency department. Sir, I think we're going to need to admit you. No, I can't. Who's going to feed my dog? Like there are these these are real people with real lives and real problems trying to make it. They're on the flight because they're trying to make it to their destination. That's, something I had never even considered, that they would pop up and be like, wait a second. I think I can make it. Yeah.
I'm a party to this decision to some degree, right?
Yeah. Okay, great point. And great point about the fact that, when we're making decisions with our patients, the calculus is including all of these complexities, like the cost, how long it'll take. Is this patient going to be nervous, anxious in their MRI machine? Am I going to have to? All of this goes into our decision making. And so this is no different, albeit more complicated from a social aspect, but still no different from the medical decisions that we're making all the time. That's always rolling through our heads.
And in fact, those decisions, when we're making them, it's often the combination of that pilot, the lead pilot or captain on board, the physician or other ground-based medical support individual on the ground, and their operations center. And it's a combination of medical considerations, as I mentioned, fuel, the timing considerations. When you're flying at 35 or 40,000 feet, you can't be at a hospital in 5 minutes. So if your intended destination is about 30 minutes away, it would take you just as long to land going to that destination as it would to make circles to get down over an airport that you're physically flying over.
And the size of the plane, right? It might not be big enough to fit in the airports that are closer. It's just not logistically possible. Or their runways are packed. Or this is, I guess, why the captain is the one making the decision, because they've got to then take your medical decision making and fit it within the complexities of all of the other planes that are flying around and all of the airports they have to choose from.
Exactly. And again, these types of decisions happen commonly. These individuals are very trained to be able to handle this. And we all work as a team to make sure things happen appropriately.
That makes me feel much more comfortable about the fact that I'm flying in a couple of days. But there is one more question I wanted to ask, and that is, so the most common being vasovagal syncope. So let's say we're called, right? I'm an otolaryngologist. I do see it sometimes because my patients do pass out in front of me. When I see it, I know it's happening, right? But if I'm called to a medical emergency and I don't know anything about the patient, what should I be doing? Right? What am I looking for? What am I worried about?
Yeah. So for syncope specifically, give it as a case example. So what's interesting about syncope is that very often individuals look fairly terrible when they have just passed out, right? They're almost by definition going to be hypotensive, bradycardic, potentially. They could be diaphoretic and pale. They're going to be unresponsive if they're truly syncopal. And interestingly, that's not necessarily how we see individuals as physicians. For example, myself as an emergency physician, I see somebody after the syncopal event has happened when they've recuperated.
Yes.
And it may be very scary for anyone to see somebody right in the throes of that event. The key thing is go ahead and safely get that person out of their chair, down into an aisle or better a galley where there's more space, raise their legs to try to shift some of that circulation. And make sure that they're, able to breathe well and they have a patent airway and are able to breathe well. It may be appropriate to give some onboard oxygen. And most commonly, that person's going to wake up fairly quickly with those simple interventions to the point that you can try to hydrate them with simple fluids.
So you thinking you might start an IV on this person? Or just like get them to drink something?
Yeah, it's actually not that common that somebody with syncopal, with either near syncope or syncope, actually requires intravenous interventions. Those individuals typically have a brief duration episode. They may remain lightheaded, but they can drink liquids. And if you can take liquids through your gut, it's actually the best way for your body to get it.
I feel so much more comfortable and so much more prepared for my upcoming flight, having had this conversation with you. So thank you for all you do for the in-flight emergencies, for taking the time to talk to us, and for making sure that we are now a little more prepared to help you if we're on one of those in-flight emergencies. So Dr. Martin-Gill, thank you so much for your time.
All right. Thank you very much for having me.
Being contacted by recruiters can be a lot. I've been at the same job for over 12 years and I still get texts and emails, sometimes in the middle of the night. Instead, get matched anonymously to find your right job. Beginly Health is a dating app for your career. To swipe right on your career, visit beginlyhealth.com/doctoring. Powered by preference, connected by passion. Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it or like it or comment on a social media post or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice, or financial advice, or really any advice. Thank us again for listening to The Physician's Guide to Doctoring.